My name again is Bill Vanarthos. I'm going to speak just briefly on two topics before I turn the microphone over to one of my colleagues. The first is caudal epidural injections through the sacral hiatus. This is just really a fancy name for a standard epidural injection, though it's unique in its own right. Okay, I don't have to tell you how common low back pain is. Probably everybody in this room either has or knows somebody with low back pain, and certainly it's a very common clinical presentation in your practice, I'm sure. Big problem, debilitates millions of Americans, and results in an enormous number of lost hours of work. And body level 3, where did that come from? That's not even part of the slide, but that's okay. I'll adjust. Annual prevalence is estimated at about 5%, and that translates into a huge number of patients. As you know, most cases are treated conservatively: rest, physical therapy, non-steroidals, and a very small percentage of cases actually require surgery. We also do percutaneous injections for pain relief. Traditionally, these have been done without any imaging guidance, but more recently, in the last decade, we've used fluoroscopy and CT to confirm needle placement. And as you can imagine, that reduces the complication rates and yields much better results. So we do these injections at the cervical level, thoracic, lumbosacral, sacroiliac joint, they're all listed there. Generally, we inject a combination of a steroid solution for long-acting effect and a little bit of local numbing medicine to get the person through the procedure itself and over the next several hours to half a day or so until the steroids start to take their effect. We do all of these locations, the SI joints, pars defects, and so forth. But I want to focus on the epidural space, and specifically through the sacral hiatus for today. For many of you, you know, if you've been in labor, you know how happy you are to see the epidural man come in your room. And this is the same epidural space, it's just a different access. What we do simply is we put the patient in a prone position and leave them in a prone position. They don't have to be moved at all, and that's because we use C-arm fluoroscopy. And with the C-arm, which rotates, we're able to look at the anatomy in a variety of obliquities. And so the patient need not be in a fetal position or move once they're laying flat on the table, and that's a huge advantage to this procedure. We use a 5-inch 22-gauge needle. And of course, we use sterile technique and local anesthesia. Basically, it's a pain-free procedure. You know, the local numbing medicine stings a little bit, it burns a little bit, and maybe it burns a lot. But that's about it. Once you've got the numbing medicine in place, really there's no pain whatsoever. We start with the patient with a prone position, as I mentioned. Place the needle over the midline, over with the sacral hiatus, which is this canal that you can see up the mid portion of the sacrum. Once we've got that in place, because some people have scoliosis and so forth, so we just want to make sure it's in the right location. We flip the fluoroscope so that we can see the sacrum in the lateral projection. Once we've got this in place, puncture the skin. As you know, the sacrum is very close to the skin level. Puncture the skin, advance the needle to this opening. It's the hiatus right here, little membrane. This is where I'll usually put in a little bit more numbing medicine because that membrane can be very sensitive. Once we've got that in place, the needle's advanced into this sacral canal right here. Very infrequently do you run into any problems. 98% of patients have a normal sacral canal. On occasion, we've run into problems where there'll be some osteophytes or something, especially if they've had trauma, some heterotopic bone, that will block the canal, but I don't think we've ever had a case where we couldn't eventually get the needle into the canal. Once the needle is in place, and by the way, the dural sac can sometimes come down to about the level of S3, so the needle is never advanced more proximal than S3 just to avoid any chance of dural puncture. Once we got the needle in place, inject the solution of steroid, and basically, if it's done correctly, the solution will pour out of the sacrum, bathing the nerve roots, and it's an extraordinarily good procedure for anybody with sciatic pain, hip pain, any kind of buttocks type pain, low back pain. It's extraordinarily effective. The whole procedure takes about 5 minutes. Honestly, it takes longer to explain what we're going to do than it does to do the procedure. And these people will generally get up off the table pain-free because of the local numbing medicine. And the steroids, on average, will keep them pain-free for, I usually tell them 3 to 4 months. But in our experience, patients have gone much longer. Usually, they testify to 9 to 12 months of pain relief. We've had a few patients actually come back for a second or third injection, and that usually takes care of their pain indefinitely. So next time you have a patient come in with low back pain, think about this. It's very easy, and it's extraordinarily effective. Does anybody have any questions about this segment? Yes, ma'am.
Have there been head-to-head comparisons of oral steroids compared to
Not to my knowledge. Not to my knowledge. But it's a very, localized, has a very localized effect. We can actually get up to higher levels by turning the table in a Trendelenburg position, allowing the fluid to flow more proximally to the lower lumbar levels. Some people are a little bit more cavalier who do this around the country, and they've actually, got like a coaxial system where they put longer needles up higher, but I avoid all that. Quite honestly, I'm afraid I'm going to puncture the dura, and I don't want to do that. It just doesn't seem worth it. So this is fairly specific, but you have patients who have coccydynia. We've had patients ligamentous laxity and pain after childbirth for many, many years, fall, unexplained, coccyx pain. I didn't mention, but oftentimes we'll just readjust the needle. They can usually be very point specific with the coccyx where they hurt, and readjust the needle and then give another shot of the steroid at that point. Besides bathing the sacral roots, we'll do a point injection at one location. But that's just something we do after we talk to them. Yes, ma'am.
Have you had success using this in people fail infusion, like robot infusion, and they're having chronic pain?
I can't recall a patient we've done with fusion, to be honest with you. Most of them are just have not had previous surgery unless it's been a discectomy or something like that. Any other questions before we move on? Okay, the next topic, osteoporosis. I don't have to tell you this person's end stage. Anybody can make that diagnosis. I'm going to give you a very cursory look at osteoporosis because it's a huge topic. There's actually a weekend-long course to become certified to interpret these studies. I don't recommend the course. But for those of us who are certified, it's a necessity. So I'm going to try to tailor this talk to suit what you need to know in your practice. What is osteoporosis? According to the official definition put out by the International Society of Clinical Densitometry, ISCD, that's the people who do this for a living. This is their definition. Osteoporosis, or porous bone, is a disease characterized by low bone mass and structural deterioration of bone tissue, leading to bone fragility. We'll talk about that a little bit later. and an increased risk of fractures of the hip, spine, and wrist. Some facts: it's a huge public health concern. It affects about 44 million Americans, about 1/7 of our population, more than 2/3 of whom are women. In the United States today, 10 million people have actually been diagnosed with osteoporosis. Of those 44 million, the other 34 million are in like an osteopenic range, low bone mass, but at increased risk for fracture. It affects 1 out of every 2 women and 1 in 4 men over the age of 50, and they'll have an osteoporosis-related fracture. It's not just a disease of women, as a lot of people are led to believe. More than 2 million American men suffer from this, and as I mentioned earlier, millions more are at risk. In fact, each year, 80,000 men will have a hip fracture because of osteoporosis, and about 1/3 of these people will die within a year due to complications from that fracture. Another misconception is that it's a disease of the elderly. That's not necessarily so. It can occur at any age, and it's responsible for more than 1.5 million fractures, broken down as follows. Broken down, that's a pun, I just realized. 300,000 hip fractures, 700,000 vertebral fractures, 250,000 wrist, and 300,000 at other locations. And the estimated cost for all this, according to statistics put out by hospitals and nursing homes, is about $14 billion a year. So it's a huge problem. What are the risk factors? Some of the risk factors that can't be changed: gender. This is generally a disease for women. They're at greater risk simply because they have less bone tissue, and they're generally at a greater risk of losing bone tissue, like during menopause. Obviously, the older you get, the greater risk of developing osteoporosis. Small, thin-boned women, body size, are at the greatest risk. Ethnicity, for some reason, Caucasian women and Asian women are at a greater risk than black women and Hispanic women. And of course, family history, low bone mass is something that can be inherited. Some of the risk factors that you can change: sex hormones, amenorrhea, low estrogen, which occurs at menopause, low testosterone levels for men, all have an effect. Anorexia, this unhealthy paranoia of gaining weight, that's going to lead to diets that are low in calcium and vitamin D, poor nutrition in general. Calcium and vitamin D intake is very important. Medications, generally long-term corticosteroid use is associated with an increased risk. Some of the neuro drugs like Dilantin, some of the barbiturates that are used for anticonvulsants, some of the thyroid medication, some of the cancer meds are associated with increased risk. Lifestyle, of course, if you lead a sedentary life, you're going to be at increased risk. Prolonged bed rest for patients who've had serious trauma and are in bed for a long period of time are at increased risk. And of course, you can find the last two on almost any list of risk factors associated with cigarette smoking and excessive alcohol intake. And so naturally, what are you going to tell your patients for prevention? You want to tell them to take calcium supplements and vitamin D supplements, get increased exposure to sunlight, stop smoking, limit their alcohol intake, and then start leading more of a active lifestyle. And specifically, you want them to get involved with weight-bearing exercise. That seems to have the greatest deterrent to osteoporosis. What are the symptoms? Well, it's called the silent disease. And so people don't generally know they have it until they've developed a fracture. And the fracture generally will present itself as a collapsed vertebra. Patients, of course, develop severe back pain, loss of height, and spinal deformities. So, if you go to bed one night and you're 6'3" and you wake up on the floor the next morning, you're 3'6", consult your doctor because you may have osteoporosis. So who should be screened? Based on what I just told you, all women over the age of 65 and all men over the age of 70. Anyone with a fragility fracture. Now, a fragility fracture is defined as a fracture from a standing height, like if I were to suddenly fall right here, collapse and fracture something, that's a fragility fracture, or less. So if you're sitting in a chair, for instance, and you topple over, go to reach for something, you fall, you sustain a fracture. That's the definition of a fragility fracture. Anyone with a disease, condition, or medication associated with osteoporosis, that goes without saying, or anyone who's considering therapy for osteoporosis for future trending. Women who've taken hormone replacement therapy for an extended period of time, and anyone who's undergoing treatment for osteoporosis to monitor the effects of that therapy. You want to see, is Fosamax working, for instance? Should I continue to do this? Should I move to a different medication or get off medication altogether? Okay, how do we detect all this? DEXA, or dual energy X-ray absorptiometry, is by far and away the best method for looking at bone mineral density. It's time and test and proven. If you want any information about the details of this, I don't want to take the time now, but go to that iscd.org website. Again, that's the International Society of Clinical Densitometry. Don't do as I did and put ICSD. You'll end up on the Islamic Center for San Diego. And so you don't want to be there. Now I get checked at the airports all the time. I'm not sure why that is. Anyway, it's similar to an X-ray, much less radiation exposure than one might think. So it's like Dr. Coates was talking about screening tools. This is a fantastic screening tool in the category of people that I just outlined for you. DEXA can detect a low bone density before fracture occurs. That's what we're trying to achieve, so we can start the appropriate therapy. Can confirm a diagnosis of osteoporosis if the patient already has a fracture. It predicts risk of fracture for the future and determines the rate of bone loss and can monitor the effects of treatment. This is a typical report. It's going to display a lot of the biographical data such as gender and height, weight. It'll give ethnicity, listed here as Caucasian, some significant clinical data. This patient, of course, is postmenopausal. We run a whole different series of tests if they're premenopausal. Generally, we're going to image the lumbar spine and both proximal femurs. We'll also image the wrist in patients in whom we think we're not going to get enough clinical information here, or it becomes impossible to image. Like, for instance, if they've had extensive spinal surgery with a lot of metal, or if they've had bilateral hip replacements or unilateral hip replacement, we'll add the wrist to complement this. From this, we generate T-scores. T-scores basically represent standard deviations. And I don't want to get into how to interpret this. That's not the point of this talk. But this is what we use to determine the category of disease that they have. Risk ratios or fracture risks are assigned to each patient, and then we give an assessment. In this patient, it was normal, it could be osteopenic, osteoporosis, or established osteoporosis, which simply means that the patient has a fracture already established in addition to osteoporosis. We trend the results. So in other words, comparisons to previous studies are tabulated in that section, and then we make our recommendations. Do you want the patient to come back in 2 years, 1 year, even less than that, or not at all? And then finally, you know, you'll have the name of the radiologist highlighted who read the study. And it's a much larger report. At our practice, it's, you know, 7 or 8 pages, but this is a summary page that gives you the pertinent information that you need to make the clinical judgment. I think that's about it.